Pathology case series. A 65-year-old male comes to the hospital with a cervical node swelling. He was run through a battery of investigations including CBC, and finally a lymph node biopsy was done. And these are the images of the lymph node biopsy. Can you make your diagnosis in the 15 seconds before I reveal it? A diagnosis of follicular lymphoma was made for this case. What are the points in favor? The differentials were reactive lymphadenitis versus a follicular lymphoma. And we know that reactive lymphadenitis is self limiting and can be treated by antibiotics or by treating the underlying cause. Whereas follicular lymphoma is a malignant disease and has to be treated by chemotherapy. So, what do we do? How do we differentiate these two? You can see in our case, there is haphazardly arranged follicles with hardly any gap between the follicles, and there is absence of mantle zone. There is usually absent or reduced tingible body macrophages, and most of these cells appear monomorphic in population. So this is how a reactive lymph node would otherwise look. You can see it has those dark and light areas. There is a preserved mantle zone, and there are numerous tingible body macrophages, and there is a mixed population of cells. If you do an IHC, your follicular lymphomas are positive for CD10, BCL6 and BCL2, whereas your reactive lymph nodes are negative for these markers. Even Ki67 will help you identify a high Ki67 in the geminal center in reactive lymph nodes. Light chain restrictions indicates polyclonality in reactive lymphadenitis. So this is how you come to your diagnosis. So this case highlights the identification of subtle findings which, when identified correctly, can lead to early treatment of the patient